Hey, Joe or Dan, did did Waji split up the articles with you guys?
He did, yeah. So I think I'm presenting one. Swytech has one. YG maybe has one or two, and then I think Colin maybe.
Hey, as a request, could we end with the arthroplasty one?
Sure.
I hope that's the one we spend the most time talking about.
Yeah, let me
Would that
text.
work? Would that
Yeah,
work? Okay.
yeah. Let me text YG and just make sure. I think YG was presenting that one, but I'll just confirm.
Okay.
I think
And
Colin was doing that
arthroplasty
one.
one.
Colin has it. Okay.
Yep. All right. Good afternoon, everyone. Sorry, bear with me just a second.
Hey, YG, I'd asked if we could. Can we do the arthroplasty article last?
Yeah, definitely.
Only because I think the others we have got some good things to talk about, but there's probably a lot more discussion on that last one.
Yeah, for sure. So we'll let's see. So we'll try to target that. That is a pretty good article. We'll target that for the end. I figured I would get us started, kind of set the tone for how things are going to go, and we'll go from there. We got a good number of people here. I'm going to share my screen. It's not much to share. We're just going to be going kind of. This is more of a discussion. Don't need to do anything too serious, but we're going to start by talking about right here. All right. So thanks everyone for making it to our journal club. It's one of your last virtual ones. So that'll be a good thing to take advantage of. We'll dive right in. Today's focus is a little bit more on some of the more complex spine surgery that we do as a whole, as a kind of division. Adult spinal deformity and some complications that come from managing that, both with primary index surgeries and revisions. Trying to understand, what causes breakdowns, what are the downstream effects. This kind of having a better knowledge of that ourselves will help our conversations with patients, even the folks that you guys see in clinic. Preliminary plan on your own, having a knowledge of this kind of stuff will help you out. And then, another topic that I thought was really useful was the total hip arthroplasty. And that's finally a paper I found that addresses a very interesting question. So Colin will give you a little bit of an intro when you get to that point about how I picked that paper. But for now, I'll get us started looking at this paper from Dr. Savage's group, which is part of why I picked it, looking at predicting reciprocal thoracic change, PJK, and revision surgery in adult spinal deformity. So as just from that title, we know that when you have a long construct, it creates a long lever arm. Longer lever arms result in seeing greater stresses at the ends. Now, if you're fusing down to the pelvis, you're mainly worried with the proximal end, and PJK is something that we're always worried about, something that we expect pretty much to happen to varying degrees, but it's going to happen, and sometimes it doesn't bother folks, and sometimes their level of demand falls to the point where it's not an issue. But getting a better idea of what can we look out for ahead of time to kind of identify which patients this is going to cause trouble for down the line. That's a useful study. So that's kind of why I picked this paper. It's out of Cleveland Clinic by Dr. Savage. It's a good overview of adult spinal deformity. What to look out for and what happens after these big cases. So briefly, as an overview, the paper does a pretty good job of looking at adult spinal deformity first as a disease process, right? It's most reliable symptom measurement is sagittal balance. So sagittal balance greater than 3 centimeters, and that's dropping your C7 line. How far in front of the posterior superior corner of S1 does that line go? Not as easy to measure on the new Visage software. You can do it, but it's not as clear. When you have a sagittal balance that's greater than positive 3 centimeters, then that's when you start noticing a change in quality of life. That's when you start seeing extra stress on your erector spinae muscles, and that causes pain, fatigue, and eventual deformity. This is a progressive disease process that leads to thoracic compensatory extension to kind of maintain and keep your head level, maintain your horizontal gaze. We also see pelvic retroversion and cervical extension, all as compensation for when you have a positive sagittal balance. Some measures that we found to have correlations with poor quality of life, in addition to positive sagittal balance on X-ray, and these are radiographic parameters, are also pelvic retroversion. So those are the two big radiographic parameters that we see affecting quality of life. Again, in a compensatory measure is thoracic hypokyphosis. So your thoracic spine will start flattening out. And that's to help maintain gaze when you have PJK. I mean, if you've got kyphosis that's quote unquote unnatural somewhere, your thoracic spine will try to compensate by reducing its degree of kyphosis. You also see loss of lumbar lordosis. Again, depending on where in the spine you see this unnatural kyphosis. Now, looking at the treatment and complications of adult spinal deformity, after we get involved, we operate to address the deformity. PJK is accelerated aware of the levels above. So technically, it's the upper instrumented variable, upper instrumented vertebrae +2. You compare the superior end plate up there, and if that's down to the top of the construct, and look at when that develops greater than 10 degrees of kyphosis, that's technically PJK. It occurs in approximately 40% of folks after ASD correction. So like I said, it's something that pretty routinely happens, but whether or not we need to operate on it, again, that's the reoperation rate, something to pay attention to. It can also cause proximal junctional failure of the entire construct, or requiring more urgent revision. Now, what are the risk factors associated with ASD revision surgery? Age, comorbidities, and obesity are what we know. Now, the goal of this study is to look at quote unquote reciprocal thoracic changes, meaning post-operative changes in your thoracic spine alignment after ASD correction. So you're looking at thoracic kyphosis, which is the paper refers to as TK, or PJK, proximal junctional kyphosis. And that's again from the top of the construct to the UIV +2. So this study wants to identify patient characteristics and radiographic parameters associated with TK, PJK, and revision surgery. So it was a retrospective chart review. All patients had undergone a thoracolumbar or down to the pelvis fusion. They had 155 patients that qualified for this study. And they had pretty good late stage imaging follow-up at about 2 years or so. The mean early follow-up was at 50 days, which is kind of late. I was surprised. I mean, I figured not everyone gets, if they get x-rays in the hospital, maybe they're waiting about 6 weeks or so to get x-rays. But the mean early follow-up visit was about 50 days. So I think you can, for the purposes of the study, it's not a problem. Likely nothing to happen in those first 50 days, but something you always want to kind of look at what those averages are for follow-up. They did a dive into the chart for some standard demographic stuff. They used 2 different software programs to look at, to obtain their measurements, which I think is a good thing to do, make sure you're not missing anything and something that's innate to the software program you're using. They split patients into groups. So basically, it was a 2x2 group matrix. There was folks who had a change in thoracic kyphosis and didn't, and those who had PJK and did not. So they compared these groups at 6 weeks and at 1 year time points. Of the 155 patients, 115 were women. They averaged 9 levels of spinal fusion. Something to pay attention to. They didn't really focus on what level they stopped at. It was just in the thoracic spine. So demographic info, they looked at age, BMI, whether or not they had a smoking history, and gender. Radiographic measurements, you can look at table 1. These measurements were all averaged between 2 observers. Interestingly, 7% or 11 patients had significantly increased thoracic kyphosis in early follow-up, and in late follow-up, 15% had showed that change later on. There's no difference in demographics between the thoracic kyphosis groups except for age. They're older in the thoracic kyphosis group for both early and late development. I think that makes sense. Sorry. All right. So early, again, there's no difference except for age between the early, those that developed TK, whether it was early or late. Those who developed early thoracic kyphosis changes were found in folks with less, that had flat back or loss of lumbar lordosis, but no other radiographic parameters were found to be associated. So again, decrease in lumbar lordosis was associated with early on TK changes. Late TK changes were found to be associated with loss of lumbar lordosis and pelvic incidence. So basically, when you have that pelvic incidence lumbar lordosis mismatch, those are the folks who are more likely to get develop changes in TK later on the 2-year follow-up. The folks who developed early on were just the flat back folks. And looking at specifically at PJK, 24% of the patients developed early PJK, and 27% developed delayed PJK, and it's the 2-year mark. There wasn't really a difference between PJK and those who didn't develop PJK, except again for age. Older folks are more likely at both time points. Those specifically looking at those who developed PJK early on, similarly, those who had a flattened lumbar lordosis and increased TPA, which is T1 pelvic angle, basically a sagittal balance measurement equivalent. Those are the folks who were more likely to develop early PJK. Delayed PJK, there is no significant association they could find with their radiographic measurements. And when you looked at the thoracic kyphosis group of patients, so when you looked at the PJK folks and looked at how many of them had any changes to thoracic kyphosis, those with TK changes were more likely to develop PJK. Given that all these constructs went up to the thoracic spine, I think you kind of expect that to be the case with this data set. So when they were looking at reoperations, 30% or 46 patients and underwent reoperations, and the big difference was the age between the groups. The radiographic parameters, looking at comparisons between those who underwent reoperation and did not, they all had there was significant difference in all the parameters except for the proximal junctional angle. Here we go. So they're pretty much all significant except for proximal junctional angle. There's a significant difference, most notable in TPA and SVA. Also, if you had increased TK or decreased lumbar lordosis, so flatter back or thoracic kyphosis, you're more likely to require a reoperation. In the discussion, they do a little bit of a review of kind of what we already talked about. Other findings that they touched upon were for pelvic measurements. There was a compensatory increase in pelvic tilt and pelvic retroversion in those that developed thoracic kyphosis. Again, these are all the standard compensatory mechanisms. Their data kind of bore out what we already knew from other literature. PJK was more common by far in the TK groups than those that did not develop TK. Again, that's kind of what we expect. Early PJK was seen in patients with, again, the loss of lumbar lordosis was the big trigger for both PJK and TK, developing those early on. So when you're hearing that last 4 or 5 times, that it kind of puts the bug in your ear that when you're doing an ASD correction, you really need to make sure you're not leaving these folks flat. You put them at significant risk of, if you flatten out their lower back to maintain their sagittal balance, they're going to compensate somewhere. It makes sense. The next area up, they're going to compensate as a thoracic kyphosis, and you're putting them at risk of PJK. So something to keep an eye on is when you're doing these bigger cases, you're locking up their lumbar spine, you really need to pay attention to their lumbar lordosis. Again, early PJK was seen in folks with low lumbar lordosis. There was also seen with folks that had a positive sagittal balance, like we talked about, increased TPA, the T1 pelvic angle, and age. So PJK was associated with those that underwent bigger lumbar lordosis corrections with surgery and preoperative TK. So
I'm gonna cut you off because we got to make sure we just keep on time for the other articles.
Sure.
And also, honestly, I can only stomach so much of this deformity stuff. Because this paper is an interesting one, but like a lot of papers, they take a lot of measurements, they do a lot of math. I'm still left with this question, which hopefully you can help me answer. Okay, so what? Now what?
So I think this is this paper doesn't do a good job of addressing that. I think once you cross the mental bridge and say, this is a deformity person would benefit from a high risk surgery, they understand that they're not going to get 100% better, but they'll get something better. They'll have chronic back pain and stiffness in exchange for what they're feeling now. So once you work that whole thing out, then I think this paper tells you what to, again, the big nugget that I got from this is you really need to watch your lumbar lordosis. That and age are the two big things that are going to make you have to come back and march this construct up higher. So we want to boil it down. Those are two things to look out for. And I think that is pretty useful, at least when you're thinking about the spine down the road. If you're ever considering or indicating people for surgery, that's something to keep in mind. So with that being said,
I think I'm wondering, Wellington and Sri, what your take is on the cumulative total of all of the deformity literature on PJK. It seems to be, to my thoughts, we started out with this concept that we were under correcting people, and so they were going into PJK, and then we swung way over to over correcting them, right? Trying to get the normal parameters of like a 20-year-old healthy control, and they would go into even more PJK or even like catastrophic failure. And it seems like we're still in that, trying to find that middle ground of what's the right amount of correction. But maybe again, maybe I'm not paying enough attention to this. So what do you guys see in this?
I think we've gotten better because we know it's an age-related phenomenon, and that the older individuals don't need to be corrected as much as the younger individuals. I see you have a good point though. You know, it's such a bummer when somebody gets PJK because it's such a big operation in order to correct it. So you want to try to prevent it whenever you can. Here, you know, the study, you know, Wajid pointed out that people who are older tend to get more PJK, which doesn't make a lot of sense, because if you're younger, you have a longer life to live in order to get PJK. So the fact that the older individuals get PJK means, in my mind, that they may not have been corrected efficiently or corrected appropriately based on age-related ideal kyphosis changes and such. So yeah, not what I would have expected based on the other literature.
And Sri, what do you see in this?
Go ahead.
No, go ahead. I want to hear what you see.
No, so I'm still trying to get a good grasp on the literature, and like you, I'm sort of confused because at least what I left, you know, last years of training with were that yes, we were overcorrecting people, and that we need to find the optimal parameters for, you know, like each patient individually. And I think that's where some of these newer deformity measurements may come in. Like I found useful things like the T1 pelvic angle or the T4 pelvic angle to get a broader picture of the overall patient rather than focusing on just the lower lumbar spinal pelvic parameters. And if you can if we can get guidelines of like how to eyeball someone intra-op on the table, you know, with what may be in like the right range, that way maybe that would kind of decrease PJK. But I agree. I don't know. I think there's a lot of variables that go into it, and I think this was a pretty decent study to try to take a crack at it. But like you said, I think when analyzing this literature, so you have to really sit down and like think about all the different variables, because so much goes into it. It can get confusing.
And part of this strikes me as an attempt by us as surgeons to try to make something that's really a continuous variable, right? Which is outcomes of surgery, into more categorical variables. And so by forcing categorical yes, no, PJK, yes or no, reoperation, yes or no, you can imagine that the definition of PJK being 10 degrees, other people might say it's 15 degrees, or other people might say it's 20 degrees. And so you're really looking at a continuous outcome measure that you were trying to categorically define and then look for correlative factors. I think the other part, the part where I would criticize this study is not in the numbers, because they've got a good number of deformity patients. They've got a lot of data points because of that. There's no patient outcomes other than x-rays and reoperations. And I think, you know, in 2021, we want to be really critical about clinical research that doesn't have a patient outcome measure. So I think as you guys critique papers, think about what if the research methodology, and think about what the outcome measure they're measuring is.
Good point. And I kind of want to take a look to see what we have here at Northwestern with these kinds of patients, and specifically this question because it's a good question. But what do you propose for patients that underwent surgery about a decade ago, and we didn't have these measures? How do we filter that in?
Yeah, I don't know that you can't go back and apply numbers. You can only do it moving forward prospectively. And I don't think you discount papers like this. I think you just really keep in mind that this is an X-ray study, right? And every surgeon has a different level or a different threshold for reoperation. So reoperation by itself isn't the most rigorous of outcome measures either. I mean, it tells you what's going on in the real world, but it's not, it's not an objective measure. Let's keep going. Wajid, you want to pick up the next article? And
yeah, well, let's go on. We're discuss Peter's looking at two-stage XLIF and PSI for correction of deformity. I think I am.
Can I make one last mention on that last paper? You don't have to pull it up. Keep moving. But I thought it was interesting the variance that they had in their angular measurements and their linear measurements using the two different systems. So you had like linear measurements, like 2 centimeters plus or minus almost 3 centimeters, and angular measurements were off by about 7 degrees. In a paper that tells you that says that PJK is 10 degrees. So keep that in mind also as you look at the literature. That I thought that was fascinating. I never thought that the digital platform we use would have that much of an impact on how we measure things.
All right. Okay, everyone can hear me? Perfect. All right, so this paper, the title is Planned Two-Stage Surgery Using Lateral Lumbar Interbody Fusion and Posterior Corrective Fusion, a retrospective study of perioperative complications. So basically the purpose here was to determine the effect of doing a planned two-stage surgery with a lateral approach, and then seeing how that affects perioperative complications for patients with kyphoscoliosis, comparing that to a control group, and the control group essentially being one stage posterior only approach. So the motivation behind this, as Wajid kind of already explained, corrective fusion surgery for adult spinal deformities becoming more common, especially as people get older, and kyphoscoliosis seems to be the most prevalent type of degenerative deformity. Surgical treatment of these patients has a high complication rate, which has been borne out in the literature.
Am I the only one hearing a lot of static?
No, I'm hearing that feedback too. I was looking. I think it's just Peter's mic. I don't think anyone else is unmuted. So
okay, just what I'm just hearing a lot of like papers rustling or something like that. So I can't hear what you're saying, Peter.
How about now?
Better.
Okay. So there's been a movement in spinal deformity surgery, obviously, to limit or reduce complications. And one of those ideas has been to stage procedures, especially with the advent of more minimally invasive type approaches, right? So that's essentially what they did here. Was they looked at stage procedure, lateral approach, lateral interbody fusion, staging that in one, doing that in one surgical setting, waiting about a week on average, and then doing a posterior approach for corrective fusion. They collected data over a 9-year period. The patients that they included in their data set had all typical parameters for kyphoscoliosis deformity, but they looked at your Cobb angle being greater than 20 millimeters, your SVA being greater than 5 centimeters, your pelvic tilt greater than 25 degrees, and or your thoracic kyphosis being greater than 60. They excluded patients that had kyphoscoliosis for other reasons other than just degenerative reasons. They followed these patients for 2 years. They tracked complications, which were defined as anything requiring medical treatment within 3 months of surgery. One thing they didn't track is amount of pain, pain medication that these patients were requiring after surgery. So that's just something to keep in mind. They tracked case-specific parameters, blood loss, operating time, those sort of things, the number of levels fused, types of osteotomies done. And then they also tracked post-operative spinopelvic parameters and some patient-reported outcome measures, including the ODI and SRS-22. So just some specifics about the two groups. So you had your first group, or your treatment group is essentially the two-stage group. So these patients had lateral lumbar interbody fusions, on average 2 to 4 level interbody discs. These discs were replaced with 6 to 10 degree cages. The patients after surgery were allowed to ambulate. The group got a new X-ray for planning of the second stage, and then on an average of 7 days later, these patients underwent posterior corrective fusion, typically involving a PLIF at L5-1, and then posterior instrumentation. All right. Also, all the groups got iliac screws. Then the second group is the control group. These groups were one stage, posterior only, included 7 of the patients actually had 3-column osteotomies. And then the types of procedures done were basically posterior fusion and PLIFs and Smith-Peets up to 3 to 4 levels. Okay, so results. 75 pages were in the 2-stage group. That was lateral lumbar interbody fusion, and then the second stage with posterior corrective fusion. And then 63 patients were in that single stage posterior only control group. The average age was 70, and across the board, all the patients were fairly similar between groups, except coronary artery disease was the only difference between the groups. And there was no difference in spinopelvic parameters preoperatively. So kind of boiling all the results down into just a few bullet points. Operative time was longer in the 2-stage group, which would make sense because you have 2 separate surgical episodes. Blood loss was greater in the control group. Deep wound infections, complications, were most common in the control group, which is the posterior only group. Revision surgery, more common in the control group related to infection. With regards to patient-reported outcome measures, there were actually better ODI and total domain SRS scores at 2 years in the 2-stage group. And then the post-op radiographs, they measured improvement from preoperative spinopelvic parameters, and they found that for lumbar lordosis and SVA, the two-stage group had a better improvement in radiographic parameters, which may or may not correlate with their patient-reported outcomes. Some limitations here. So, it's a retrospective study. All of the single-stage posterior-only control group were all done before a certain time period, and then all of these 2-stage groups were done after a certain time period. So that introduces a little bit of bias, I guess. It's a single center study, relatively small number of patients. They weren't matched by number of levels or anything. And also, I think, the posterior only group, that included 7 patients that had 3-column osteotomies, which I think has been shown to affect outcomes. So I think that's, if you remove these patients that had 3-column osteotomies from the control group, may that have changed any of the differences found between the 2 groups at the end in terms of complications. So discussion points, my takeaway, essentially, it doesn't seem like there's really any downside in staging the procedure and aiming for a more MIS approach if it's indicated, especially if you can get the patient up and walking post-op day 1. So there's a table here that basically looks just within the 2-stage group. And they showed patients that get up post-op day 1 versus patients that get up post-op day 2 or later. Those who get up post-op day 1 have fewer complications overall compared to those who don't get up post-op day 1. I don't think it's a super strong finding. It was 17 patients versus 19 patients. But it was a finding that they called out or they found in the results and they talked about in their discussion. Back to the complications, the real only difference in complications was that the posterior only or the control group had a higher deep infection rate. And again, maybe if you excluded the patients that had 3-column osteotomy or those outliers that maybe had really long surgical operating time, maybe that'd be different. Maybe there's greater improvement in the spinal pelvic parameters in the 2-stage group, which these authors seem to find. And also they found better patient-reported outcomes at 2 years. Which here's all the, you can see here, all of the the patient-reported outcomes are down here. And this is the control column, or the control group, and these are the 2-stage group, and they found, pretty significant differences in patient-reported outcomes. I can't totally explain that. If you guys have ideas about that, I'm, interested, obviously, but I think it's just more the MIS approach potentially, and the better correction on X-ray may have a part to play there.
So thanks for putting that together, Peter. I think for me, the quick important parts of this were table 2 and table 5. So if you scroll to table 2, and then one thing to keep in mind is when they did a comparison between these two groups, preoperatively, the degree of deformity was more or less the same. So and you mentioned a couple times the 3-column osteotomy. If you take them out of the all posterior group, I think that's cheating because that discounts the strength and the ability to correct that you get from the XLIF. So the reason those guys don't need you to do so much work posteriorly is because it's such a powerful technique to correct the anterior column. So if you're going to go posterior only, you miss out on the strength of that technique, and you have to compensate by doing a lot of your work posteriorly through big osteotomies. So the blood loss is something that if you're not going to use the 2-stage, you don't have to wait a whole week, but if you're not going to do the 2-stage technique, use a powerful anterior column correction, I think that's a bullet that you have to fight. I think one of the big things table 2 shows is, while yes, the overall operative time was longer for the 2-stage, if you look at operation time first and second, the longest time a patient was asleep straight was 300 minutes versus the control was close to 400. So you're talking from 300, 400 minutes, that's over an hour and a half. And if the attending on can tell you, I'm sure that's the later you get in the case, the more you get worried about someone tipping over the edge, someone tanking, someone developing DIC between your 300 and 400th minute, when you've got someone that's got a ton of blood loss. Another thing that they mentioned was the number of folks that underwent quote unquote massive EBL loss in surgery. They were all posterior. They were very rarely in the 2-stage group. So it is like, while it's if you look at just the overall operative time, it's longer for the 2-stage. They weren't on the table for a single period of time for longer. So that's much better for the patient, especially when you're crossing 300 minutes, you're getting towards 400 minutes. Every minute there counts, and that's a big deal. And then table 5, again, better radiographic outcomes pretty much across the board. Look how many of these are significant. It's not saying that everyone needs that anterior correction, but you can get, I think, better, more powerful correction by involving the anterior column than you can if you try to just do posteriorly. Even if you have to do your big osteotomies, then like you talked about, you lose a lot of blood. And it has a higher risk of complications besides just the operative time that we talked about.
So I think very powerful. Zoom in on that table, and I think there's another story here. I would agree with everything you guys are talking about, that there is a less operative time, less infection rate. I think that's a given. I think one of the biggest confounders for me in this study, Peter, you hit it on the head, which is that these were not consecutively like managed patients. These were not, again, this is where the randomization, a randomized trial, which would account for this confounder, would be helpful. These are patients that they used to treat open, and then they switched to an MIS technique. And during that time frame from 2010 to 2018, you need a little perspective to know that our understanding of deformity changed quite a bit during that time, like we talked about in the first study. Trying to find the right amount of correction, right? Under correcting, then over correcting. So if you look at this table right here and you hone in on their PI-LL mismatch in the control group and the 2-stage group, right? Their control group had about a 12.4, whereas their 2-stage group was substantially down, right? And I think significantly down, and also numerically, it seems to be clinically relevantly down. So to me, that just tells me that they got better at matching correction over time. Now, yes, maybe the lateral made it easier for them to do, but you can also match correction with posterior-based procedures. So I'm not fully surprised based on their radiographic outcomes that their clinical outcomes also showed a difference, right? So my take home point is, yes, the lateral can be done. It can be done safely, 2-stage, but I would put a fair amount of weight into the confounder of the idea that these patients weren't consecutive, right? Not consecutive, what's what I'm looking for. Concomitant, they weren't treated at the same time. Wellington, Sri, what do you guys think?
Are we sure that the 2-stage patients came later though? I didn't catch that from the paper. You're right, they're not consecutive, but do we know if they're later or earlier, or they're just kind of intermixed in between?
I think they listed that in their limitations when they listed their own limitations.
Yeah, so they performed an average of 7. Oh, no, never mind, 7 days after.
It makes sense that it would be later just because
Yeah.
it's a newer procedure, right? So that does make sense for that.
Yeah, they're showing it there. Again, I'm not saying that you're going to always have randomized data. That's not the point. The point is to understand what the confounders might be. And here, time is a confounder, right?
Yeah, no, I think those are good points. My takeaway was that I was surprised that the lateral interbody fusions restored lordosis as good as the posterior column osteotomies. I guess I never sort of thought about it that way. I think there are a lot of advantages to doing somebody with a lateral and then going and posterior backing it up. And you don't necessarily need to do that in a 2-stage, but if it's 3 or 4 levels, it does make sense to do that, for the proper patient. I always thought that you were accepting the fact that you cannot get as much lordosis when you compare it to, like, let's say Smith-Peet osteotomy, multiple SBOs at consecutive levels. This paper indicates to me that that's just as good, if not better. I probably wouldn't say that is better because of the reasons that are noted, but it's just as good, which again, I'm a little surprised at. And some of the cases that they showed did show, some restoration of lordosis, which I never really accepted or thought that it would be an advantage for a multi-level lateral.
I think their posterior procedures were open also, Wellington, as opposed to some of the literature that talks about percutaneous, posterior instrumentation. So I would bet that they got some additional correction posteriorly, right? Facet releases.
Yes, right.
Decompressions. That might account for why they got so much better correction. Also, again, it might just be technique. They may be paying more attention to correction,
right.
in more recent times. All right, should we keep moving?
Yeah, we'll move on to are multi-rod constructs required for pseudoarthrosis with adult spinal deformity? Joe will kind of take lead on this. This is out of Hopkins, and Dr. Cabage is one of the authors on it. But Joe, if you want to take that away.
Yep. All right. Sorry about my sloppy annotations here, but this was a study that was just published this year in the Global Spine Journal, looking at the approach to pseudoarthrosis after adult spinal deformity using multiple rod versus using a normal dual rod construct. So it's most of the authors are from NYU. I think Dr. Cabage is at Hopkins. So this was a retrospective cohort study done on patients between 2012 and 2017, looking at rod fracture rates and persistent pseudoarthrosis for patients treated with dual rod or multi-rod constructs. So basically, these are patients that already had a prior adult spinal deformity correction surgery, went on to get a pseudoarthrosis at least one level, and then had a revision surgery. And they're looking at whether for that revision surgery, it makes sense to do regular dual rod construct or a multi-rod construct. So obviously we all know the rate of pseudoarthrosis is, quite high for these adult spinal deformity surgeries. When you extend the fusion to the sacrum, 42% rate of pseudoarthrosis. So this is a very common problem, and it is clinically relevant because it leads to worse patient-reported outcomes and decline in basically a loss of your deformity correction. So more recently, this multi-rod construct idea has come into play, and biomechanically, there's been quite a few studies showing that obviously, if you have multiple cobalt chrome rods, that's going to be biomechanically stronger than 2 rods. But what hasn't been shown is if that's clinically relevant in terms of rates of revision, rates of rod fracture, things like that. So this study basically looked to take their population of patients that had a revision for pseudoarthrosis and determine whether or not the multi-rod decreased their rates of pseudoarthrosis after the revision, or affected the rates of rod fracture, reoperation, and then complications, basically. It was a small study, so it was 23 patients in the dual rod group, 23 patients in the multi-rod. They defined pseudoarthrosis as on CT scan as well as on clinical exam, so it's all symptomatic pseudoarthrosis. All the patients, they use 5.5 cobalt chrome rods, so that was consistent among all the surgeries. They didn't all have a consistent construct for the multi-rod, so they just had to have at least one additional satellite or kickstand rod. So some patients had multiple kickstand rods or multiple satellite rods. So that was a little bit of a confounder. In terms of their preoperative demographics, there was no difference in any of their patient characteristics or demographics. So BMI, frailty, comorbidities were all the same amongst the groups. I'll go to the table here. So no difference between the dual rod and the multi-rod and any of their preoperative characteristics, including osteoporosis. The surgeries I thought was kind of interesting. So there was no difference in terms of the number of levels fused. There was a trend towards significance for the operative time, which didn't make a whole lot of sense, that the dual rod surgeries would take more time than the multi-rod. No difference in the number of 3-column osteotomies, posterior column osteotomies, or interbodies. What they did show a difference in was the use of BMP. So more of the patients in the multi-rod construct group had BMP used at the time of the revision surgery, and more they required more blood transfusions with the multi-rod construct. So a little bit, probably a little bit more invasive, a little bit larger blood loss, although that wasn't quite significant because of their small sample size. When you look at their outcomes, they looked at the 2-year outcomes. Looking at fusion grade, there was no difference in the fusion grade at the pseudoarthrosis level. So both of them achieved essentially equivalent levels of fusion. No difference in rod fracture, no difference in reoperation, wound infection, hardware prominence, or PJK. But I think it's a little bit hard to interpret because their numbers are so small. So, I mean, the 9% compared to 0 for PJK, which they discussed in their discussion, is probably trending towards significant, but not significant in this study. So the complications, they also showed no difference in any of their complications, but sort of ran into the same issue. When you only have 23 patients in one group, 24 in the other group, a little bit hard to find statistical significance in the 2 cohorts, but their complication rate overall was 29% in the dual rod, 35% in the multi-rod. And my overall takeaway from this was that, the multi-rod construct, while biomechanically stiffer, likely does not make a large difference in the rate of pseudoarthrosis when you're already revising for pseudoarthrosis. I think, it's also a biologic problem. So it's not necessarily a stiffness of the construct kind of problem. And I think that's sort of what panned out in this study with small numbers. So it's like a lot of things in orthopedics where, just because something is biomechanically superior doesn't necessarily make it clinically superior. And I think that's what they showed here. But overall, I think you need a larger study with hundreds of patients to tease out whether the complication rates are really different or the rod fracture rates are really different over the long term.
Yeah, I thought same things as you, Joe. And I immediately what stood out was like, okay, it seems intuitive, but low numbers. And wonder if we get, like 150, 200 patients, we can find a difference between the two, because I would think so. But looking at the table 3, you don't really see any major trends. I mean, other than the one that you pointed out. So interesting question. But yeah, and then the other thing is like, if make sure there's no confounders with people with vastly different kind of biological differences, like diabetes and other things.
Yeah, exactly. Joe, if you were to sort of criticize the statistical error likely present in this paper and in their, sort of conclusions, what would you say?
I mean, I don't think they controlled for their confounders well enough. I mean, you have patients that had vastly different surgeries by different surgeons, and they're trying to come up with a conclusion on one minute aspect of those surgeries, and it's just not a well-controlled study.
So controlled is one aspect of it, but there's also power, right? Statistical power.
Yeah. So it was underpowered for
underpowered, right?
What they're trying to conclude.
Exactly, which leads to what type of error? Type 1, type 2?
I believe it's type 2, right?
Yeah. So that type 2 error, can you unshare your screen for one quick second?
Yeah.
A type 2 error is,
hang on one second. I think it's type 1. I think it's type 1 error. Type 2 error is a beta. Type 1 is alpha.
So yeah, I think underpowering is type 1, I thought.
Yeah, I thought it was the other way around. Am I totally wrong? This is the picture that I use whenever I'm thinking about type 1 or type 2 errors. So like, but this picture could be wrong. So if I'm wrong, somebody correct me really fast. But my recollection was that type 2 errors, which are alpha errors, are ones where you assume there's no difference, but there actually is. And that might be a sample size issue. Type 1 errors are assuming there is a finding erroneously when there is not one. So sort of like a false positive, type 1, false negative, type 2. Is that?
Right.
Yeah,
that's my interpretation too.
Yeah, I was type 2 is O.J. Simpson, type 1 is Shawshank Redemption. That's how I remember it. And, same thing. Yeah.
Okay.
Yeah. So this study then is assuming that there's no difference, but there could be a difference
if you were
if there are more patients, right? So I would say this is type 1 error.
Type 2, because you're saying there's no difference when there could be one, right?
That's.
Am I wrong?
That's type 1 though. That's type 1. I think type 1 is when you're saying there's no difference, but you don't have enough patients to say that you have enough that there is a difference or isn't difference. So there's not enough power to show either way, but you're saying there's no difference.
I think I'm getting them mixed up in my head, so I apologize for that.
I thought power was 1 minus the type 2 error. So like the accepted power, like back in basic stats, is like 1 minus 0.2. So you're 20% type 2 error. So if you're underpowered, your power shrinks and your type 2 error goes bigger. But I don't know. Sorry, we can. I'll look that up.
Clearly, another article we'll pick next time is making sure we all understand the difference between type 1 and type 2 errors. I think
we'll get Dan Johnson on here. He'll
however you want to describe it, understand that in this setting, an underpowered study may not appropriately let you make a definitive statement about differences present between two groups. Right? And it's usually that an underpowered study might come back with a null finding, a null hypothesis finding, when in fact it's actually true. I don't remember type 1 or type 2, but anyway, that's I think the way to take away from this one. Hey guys, I've got about 10 minutes left. I know that we've got other papers to cover. Is it okay with everybody? Sorry for whoever was going to do the ALIF.
I was just going to run through the ALIF at the end, so we'll go to Colin. We'll talk about the total hip. I think that's got some valuable stuff.
Yeah, the ALIF paper basically shows you that poster instrumentation isn't as rigid as you think it is.
Yeah, we can shove a cage in the front, and it works.
And I think we've all done cases like that, right? Where we go in, or you've seen them with us, where we do an ALIF, even with stable implants in the back, and we get correction. So let's talk about the hip replacement one, because I thought that was interesting.
Yeah.
Okay, I'll talk about that one. Waji, if you want to put that paper on your screen, I've written down all my notes, so I don't need to share mine. So I'll go through it really quick. That way Dr. Patel has time to give us his thoughts on it. So the hip-spine relationship in total hip arthroplasty, how to execute the plan. This was a recent article out of HSS published in the Journal of Arthroplasty with definitely the arthroplasty point of view on this topic. So the article, which was a review article, aimed to examine the role of spinal pelvic pathology on the postoperative total hip in terms of its influence on instability, dislocation, and revision. They noted 2 spinal issues to consider for optimal management and implant stability, optimal impingement profile and implant stability. One was spinal stiffness, and the other one was spinal deformity or sagittal spinal imbalance. So they outlined kind of the target, the historical safe zone for cup placement with an inclination of 40 degrees plus or minus 10, and then antiversion of 15 degrees plus or minus 10 degrees. And so they called this into question, and they noted a hip spine classification system, which I believe was published by the senior author prior to this paper, where they note 4 groups of patients, 1A, 1B, 2A, 2B. So essentially the ones have normal spinal alignment. The 2s have what they call a flat back deformity. And then the A's have a normal spinal mobility, whereas the B's have a stiff spine. And they note different inclination and anteversion targets among the various groups. They next went into how to achieve the goal here, and they said there's no perfect way. They may require computer-based navigation and robotics in order to perfectly place the cup. They noted their pre-op workup, saying which x-rays they get, the standing and seated lateral x-rays of the lumbar spine, as well as their normal hip x-rays. Then they went over the hip spine classification again, and they noted a study where they had a 5-year no dislocation rate of 99.2% of a number of patients, which I don't have written down on my cheat sheet here. And then they also noted that the high-risk patients, what they consider 2B patients in this classification system, should receive dual mobility total hips. And then they went over 5 different case examples of patients in different categories and what their goals would be, essentially just stating their classification system. So I thought it was an interesting look at this topic from the arthroplasty standpoint, but some things it does not really touch on in my mind were kind of looking at the spinal side of things as far as, does this affect anything that you do during your lumbar surgery with someone that has a pre-existing total hip replacement, which may be a completely different topic. But I thought that was one of the things I kind of wondered, because, we look at patients that already have their spinal pathology and then get a hip replacement. I was kind of wondering about kind of the other way around was my biggest question. I didn't have many patients to go over since this was a review article. I was just kind of curious to hear everyone's thoughts on the study.
I was fascinated by the comparison of the sitting and standing x-rays. It's fascinating how different they look, especially side by side. And I think that there could be a lot of potential with trying to identify patients. I mean, the simple sort of concept, it might be like, some patients don't get better, their stenosis symptoms don't get better when they sit. And it may be because of the parameters like during sitting that don't change. And that maybe if they do change, then you'll find that they actually open up their canal or what have you. But this may lead to other types of research that I think could be interesting, like PJK, like, where to do what levels to include on your surgery. I just, yes, the whole sitting X-ray I never thought about comparing the both of them and thinking that they could affect what we do electively.
I'd echo that. I think that's a really cool, this is one of the things I took away was this image right here. And as a way of assessing for the mobility of the pelvis with regards to retroversion and anteversion, right? Because we always look at standing films. I don't think I've ever looked at a seated X-ray before, intentionally. And this might be, and I'm wondering if our literature in the spine world has any description of assessing sort of pelvic mobility in this way, right? Because someone like this figure where there's a lot of motion, and I think maybe it's the next figure or the next, maybe it's the page before, maybe it's page 3. They had some images of folks whose pelvis really don't mobilize. I'm not sure where I saw it now, but anyway, the idea that there's mobility and you can measure it with seated imaging. There you go. That's a nice one, right? Somebody whose sacral slope doesn't change, suggesting a fair amount of stiffness there.
Right. And you got to think there are ramifications on when we fuse somebody when they are different compared to when they're not different. And I don't know what they would be. I'd have to think about it, but that certainly could lead to biomechanical alterations. I would say more so in the individual that does move. Yeah, definitely.
If we fix them in the wrong spot, you mean, right?
Well, just fusing them. Let's just say we're doing a L2 to S1 fusion on an individual on the left, on this individual who doesn't change very much.
Yeah.
Probably not a huge difference, but the other individual, like the one, two pages before, if we fuse them from L2 to S1, I mean, they're sitting a lot different, right?
Yeah, I see what you're saying. Yeah.
Especially if we sit, fuse them in a standing position. We're fusing them with a Jackson table, right? So
yeah. So we really alter the requirements of their pelvis for sitting, even though we've optimized them for standing.
Correct. Yeah, correct. And maybe they're miserable while sitting, and we don't really think about it that way.
Yeah. And then the other picture that I really loved out of this article, if you scroll down, they do like a 3-dimensional visualization of what the pelvis and the hip look like in relative motion. And this is something that I've struggled with as I think about this problem. Keep on going, bud. It's there. I've always sort of tried to think about, okay, how does the pelvic version affect acetabular cup placement? It's that image right there, number A. Right. And I think I underappreciated the impact of pelvic alignment on version for hip replacements.
Mm-hmm.
And this image by itself for me was super helpful in understanding how much, a retroverted pelvis uncovers the anterior hip. Right. And so if you have somebody with a lot of pelvic version and you line it up like you'd line up a standard hip replacement, they're at an increased risk for anterior dislocations. And then to Colin's point, I started thinking, well, these folks that get hip replacements and then we fix them, right? We move them from one position of retroversion of the pelvis to a more vertical pelvic inclination here. Are we putting them at risk for a posterior dislocation? And I know there's been articles describing post-operative dislocations, right? After spine correction, seeing people with long-standing hip replacements then all of a sudden dislocate. So I think it might be a two-way road, to your point, Colin, that this cuts both ways. Which again, for me, this visual was really helpful. I'm not sure how other people have thought about this. I'd love to learn.
Some of the discussion that the paper kind of goes into, I agree with, was super interesting when it talks just about how much uncoverage you get with the hip range of motion. something that wasn't quite, it wasn't worded well enough for me to understand, and this is more on my end than the paper, but the measurements, like the updated guidelines they gave for, 45 degrees of inclination as opposed to 40, increasing the anteversion, and this is of the cup, not of, like, in total hip, you talk about combined version between the femoral implant and the cup. This is talking about the cup's positioning. Increasing the anteversion of the cup is all relative to the functional pelvic plane. So they are talking about not just using your standard X-ray and trying to base things off of like the transverse acetabular ligament. If you go into the discussion, they talk about the fact that, when you increase the anteversion of the cup relative to the patient's quote unquote functional plane of the pelvis, it might still be retroverted compared to what their like transverse acetabular ligament. So some of this is still pretty like conceptual. It's hard. You're not gonna like take in the OR and try to retrovert, see what's going on with their cup coverage when you have them on a table. You can't really do that. So it's not so clear.
Yeah,
it's hard.
I think you, sorry to cut you off, Wajid, but I think you kind of explained what I was thinking in the sense that why I had tough time kind of understanding, what's going on here was, with the hip, we're looking at the pelvis, people with sagittal deformity and retroverted pelvis when they're standing lateral because they're actively compensating, and we have our parameters to try to correct that. But it's different when they're laying supine on the table for a hip replacement. And I don't know how hip surgeons can kind of assess that accurately. Like, I'm thinking, yeah, you can fix it, the spine problem before or after. It's still incumbent on the hip surgeon to really figure out where, I don't know, to put the cup. It still seems like a hard problem from their standpoint, I think, is what I'm trying to get at.
This reminds me of a lot of the discussions that happened about 10 years ago when, we started talking a lot more about sacral slope, pelvic incidence, pelvic tilt, and the relationships there. And then trying to sort out how we assess that standing versus prone in the OR, right? And how do we get to optimal alignment of the lumbar spine so that we get a normal pelvic tilt, pelvic version, right? I think those same measurement difficulties are going to exist as we think about hip replacement. But at least I think articles like this help shed some light on what the underlying problem is. And again, this is such an abstract concept, right? That you're talking about the moving parts of the spine, the pelvis, and the hips, and understanding how each of those anatomic parameters moves in relation to each other. So for me, again, it's just tough to visualize. And this was a reminder of how effective a good picture is at conveying a really a complex problem.
For me, it was, I could see myself doing some total hips in the future. So I was really trying to get a better understanding. This is one of the few papers that talks about what to do when you have a stiff spine, not looking at total hip done first and then looking at the spine after. And the interesting thing is, I'm just thinking, posterior, you don't even get next. You don't really get X. You don't get to do the posterior total hip under an X-ray. You go anterior. You have this X-ray. That's all you get. You get a static one-time shot, position the person sitting on a HANA table with post between their legs. You want to get the pelvis to look somewhat flat like this, and that's what you call your working X-ray. Now, when you get that C-arm shot, you can tell your abduction angle and your anteversion angle, but it's all relative to what the patient's pelvis looks like when they're like Dr. was saying. It's just a single position when supine. That's all you get. That's all the information you get for the cup. So it's a tough call to make. And they kind of like take away the one reference point I was going to say was that you have the TAL and you always have the patient's native anteversion, but then in the discussion they say, hey, when their functional plane might not be what you're looking at anatomically. So it's a nice thing to think about. I don't know that I'm going to start sticking cups in a little bit more anteversion just because they have a stiffer spine. I don't know that that's the answer, but it's an interesting thought process.
I think we're going to try to get Joe. I don't know. Did Dr. Kelly agree to come and speak?
He did. Yeah, he's coming in August.
So Mike Kelly is going to be one of our visiting surgeons guys in August, and we specifically asked him to talk about this which is the relationship between the hip and the spine in adult deformity.
Awesome.
I think it might be nice, Joe, if we can get this article to our joints team.
Yeah.
Before we have Dr. Kelly come and speak.
Yeah, I'll send it out and maybe do a joints journal club beforehand too.
Yeah, this might be, again, it's not definitive, and it's definitely written from a arthroplasty surgeon's perspective, right? But it's good to see their perspective, and I really am curious about the whole sitting X-ray. I know I've seen sitting X-rays used to assess for and try to predict thoracic compensation postoperatively. But I don't think, Wellington, I've seen a sitting X-ray used to determine pelvic mobility.
No, I mean, I think one just very easy study is to do like 100 patients and see who moves and who doesn't. And I mean, that's just very simple. I think that idea in and of itself is a study.
Yeah. I would be worth, before we do that, to see what's in the literature, if there is stuff.
Yeah, absolutely. Absolutely.
Yeah, that's a good point.
But I think that's just a super interesting insight that they showed through this. So, hey guys, I apologize, I got to run, but thanks for running a great journal club.
Yeah, thanks for making it. Appreciate everybody's time. And we'll, if anybody any questions want to talk about this papers more, we can always have a different conversation. But we are running a little over time, so thanks everybody, and we'll kind of end it there.
Great article, guys.
Yeah, good job. See you guys.
Thanks. See you guys.
Thanks.